Alrighty, so hi there everyone. Thank you so much for being here with us today. My name is Kayla Smock and I am the president and founder of the Occipital Neuralgia Foundation. And today I am so happy to say that I am joined by Dr. Angelo Leto Barone, who is a craniofacial and pediatric plastic surgeon who's taking a special interest in occipital neuralgia. So thank you so much for being here with us today. I'm really excited to have so many of our questions answered.
Of course. Thank you so much for inviting me. It's a pleasure to meet you and to hopefully shine some light on such a important and poorly known pathology.
Yeah, no, absolutely. Yeah, and for everyone that's watching, just for a little bit of background about the Occipital Neuralgia Foundation. So we are a registered 501c3 nonprofit organization, and there are three aspects to our mission. So first and foremost, making sure that we are providing support to those who are dealing with occipital neuralgia, but also to their caregivers. The second aspect to our mission is to educate the public about occipital neuralgia, and then lastly, ultimately, fostering research into the causes and treatments of occipital neuralgia. And then from time to time, we do host these interviews just to get a better idea of what occipital neuralgia is, what might be up and coming in terms of research, what are some of the treatments, what does diagnosis look like, talk a little bit about insurance, and hopefully get many of our questions answered. So that kind of brings me back to why you are here. So I understand that you have three research fellowships at USC, Harvard, and Johns Hopkins, and that kind of led to a integrated plastic surgery residency at Johns Hopkins University of Maryland program as well. So all of that kind of being said, can you talk to us a little bit about what sparked your interest in treating occipital neuralgia?
Absolutely. I was a resident, as you were saying, in Baltimore. And one of my attendings, so one of the people who train surgeons, um, was actually one of the first people who pioneered and really advanced the field of occipital neuralgia. And our program would always have all of us residents rotate through his private practice so that we could actually see not only the technique, and we could actually learn it, so we could go out in the world after training and help patients all over the world, but also be exposed to the life-changing effects that such powerful surgery can actually do.
Sure, that's really special. I mean, it's something that I mean, it's a condition that you aren't able to physically see, right? So the pain is, I mean, it's oftentimes for many of us, the pain is constant. So any type of relief, as you mentioned, is going to be life changing. So, kind of going off of that, let's start from the very beginning. Can you talk to us a little bit about what occipital neuralgia is?
Yeah. So occipital neuralgia, the word neuralgia means pain that is of nerve origin. Okay. So many people often discuss occipital neuralgia as migraine pain. And the first differentiation that I think that needs to be done is the fact that what plastic surgeons can treat is actually the trigger to the migraine and not the migraine itself. And it's an important distinction, because when we talk to our colleagues very often, either the primary care physicians, the pediatricians, or the neurologists or the pain service, we all very often get a little bit of resistance, saying that we're doing surgeries that are not actually validated, or they're sham surgeries, etc. And what I always say and state while we do these educational lunches with colleagues, etc., to show them that this surgery is actually so impactful and so important, is explaining to them what the cause of their migraine is. And we always say, we don't treat the migraine, we treat the trigger to the migraine. So occipital neuralgia is a neuropathic pain that happens for compression of the occipital nerves. And if you saw a drawing of the occipital nerves in the back of the skull, in this area that's called the occipital area, we have 3 nerves on each side. So we actually have 6 occipital nerves in our skull. We have the greater occipital nerve, which is much larger than the others, and then we have the lesser occipital, and then the third occipital, which is actually very, very small. And what they do is basically they're sensory nerves that emerge from the muscles in the back of the neck, and then they basically irradiate right here and provide sensation to the back of the skull. And of course, they're connected to all the other nerves of the skull through connections. So sometimes when patients have concussions, it's very typical. I take care of occipital neuralgia in the pediatric population, so in children. And very often we hear of trauma that has occurred when they were 5 or 6 or 10, and had one patient who fell off of a inflatable castle during a party, and somebody removed the plug, deflated the castle accidentally, and the child fell, hit her head, and we were actually able to help her after she developed this pain that nobody believed existed. Which is one of the typical stigma of these patients who often are seen by neurologists, well, first primary care physicians, then neurologists, then pain team. Everything has been attempted and nothing works. And the truth is that what happens is a lot of scar tissue formation right on where the trauma is, then the concussion is. And that can actually create this scar, and that leads to compression of the nerve. And once the nerve is compressed for a long time, it can, of course, be affected and starts triggering a migraine. And the typical symptoms are very peculiar, or very characteristic. And of course, you need to be trained to be able to understand that. Very often we have patients that come to our clinic and say, I have had, pain everywhere. Is this occipital neuralgia? No, very likely that is not occipital neuralgia. The patient with occipital neuralgia comes with very specific signs that are typical of the nerve compression for scar formation in the back of the head. And they come and say, doctor, like my pain, they take their index finger and they say, the pain is right here. And they actually point right where the nerves are. And then they say, and I saw it in many of the questions that the audience sent before tonight, and the pain is typically irradiated. It radiates all the way up here, and then they hit and involves the eyes. And it's very typical. And everyone, when we have them draw where the pain goes, textbook, everyone tells you starts here, goes all the way here, and then they circle the eyes. Once that is there, we know that we're very likely in front of an occipital neuralgia case. Of course, we want to make sure that everything else has been ruled out, is a diagnosis of exclusion. And then I see them in my clinic and I do what we call a diagnostic block. And the diagnostic block is done with a high volume of lidocaine or any local anesthetic with epinephrine, because there is also a vascular component to that. And we'll go back into that for another question that was asked. And what that does is really distends that area because of the high volume. It gives vasoconstriction. So if there is a vascular component, that also gets basically taken care of. And these patients tell you, oh my God, I've never felt so good about, the pain in my head. And I usually send them for a couple of weeks, tell them to have a diary and record every single event that they have. And then we match it with one that, with a typical calendar, migraine calendar and diary that they would have before, in frequency and intensity and how many times a day, etc. If the decrease is stark, then we know that this is something that definitely can be treated with surgery.
Sure. Okay. Thank you for walking us through that. I do want to go back to when occipital neuralgia is first brought on for patients. So we just talked about the relationship to concussions, right? So when somebody has a concussion, is the pain typically presenting immediately after the concussion, or could this be something that's brought on several years later? Is it often linked back to concussions, or can it also just come on suddenly for patients? What does that look like?
Uh, any of the above.
Okay.
Most patients will require some sort of lag time before symptoms even arise, and it makes sense because some scar needs to form, but sometimes it can
Hmm.
be acute due to immediate injury, even though that's more rare. Um, the important thing that is something that we need to talk about is the fact that as time goes by, symptoms worsen, and the patient is usually not able to function. And typically, these are straight A students who all of a sudden, because of the concussion, go to the inability to concentrate and do well in class. They are not social anymore. They cannot do just regular tasks. So the quality of life really decreases quite a bit. And and the surgery really makes a huge difference in these patients. There was another part of the question that you were asking that is escaping me. What was it?
Um, if the pain ever comes on suddenly for patients, or is
Yeah,
it typically always?
related. Yes, I
Hmm.
have noticed, and I have no data to confirm this, but I've noticed that in some areas, in some patients that have, for example, bilateral breast hypertrophy, so patients who usually undergo breast reductions, in my practice, um, I've noticed some sort of weak association with occipital neuralgia, and I think that actually makes anatomical sense because uh, the nerves actually exit some muscles in the back of the neck, and these muscles are some of the muscles that are actually necessary for you to keep your neck erect and straight, um, which of course you need to hypertrophy if you have large breasts that are actually weighing you down.
Hmm.
So to me, it makes sense that if you have those neck muscles hypertrophied because of this constant need to strain your neck, it will make sense that those thickened muscles would actually compress the nerve more. In fact, when we release the nerve, we have to actually go through the muscle and release in multiple points where it can be um, uh, compressed. So we need to decompress multiple areas. So that is absolutely possible. And I've seen cases of occipital neuralgia where no true concussion was actually present in the history when we met the patient.
Sure. Okay. Thank you. And that helps to answer one of the questions I remember that was sent in. Someone had asked if their posture can affect their pain. So that
Absolutely.
kind of. Hmm.
Think about the fact that now we're constantly hooked to our phones and
Yeah.
constantly have a very bad neck posture. I wouldn't be surprised if in the next few years we're going to see a higher rate of occipital neuralgia due to the poor neck posture that we have. Because again,
Hmm.
if you alter your anatomy and you could potentially either stretch the nerves, compress the nerves, etc. There's not a lot
Hmm.
of data, at least that I know of, um, about this, but I wouldn't be surprised if this was something that came up in the next few years.
Sure, absolutely. So now going back to diagnosis. So you and I had chatted briefly. There was a study that came out recently that average time to reach an accurate diagnosis of occipital neuralgia is almost 2 decades, which is extremely disheartening. And as you just mentioned, the timeline is just so important for these patients. Do you have any recommendations for people who they might not have been diagnosed yet formally by a physician, but they may be following us. They may um, have done their own research and have a feeling that they might be dealing with occipital neuralgia. Who should they be seeing? What type of specialist should they be seeing?
So usually these patients are already patients that have been evaluated multiple times by multiple physicians. I
Hmm.
think a good starting point is always the neurologist, because the neurologist can rule out any possible other causes of migraines. Of course, we cannot think of anyone having a migraine having occipital neuralgia, right? And there can be dangerous causes of migraines, such as masses or nerve tumors, brain tumors, etc. That, of course, the neurologist is the right person to rule out and make sure that there is nothing else going on. Those are also rare, but when we practice medicine, we always have to make sure to be safe and first do no harm. So the first thing is make sure rule out any other causes of migraine that could be important to be ruled out first. After that, the neurologist, especially a good neurologist who knows and is in touch with a plastic surgeon who provides the surgery, who's trained to do the surgery, should refer directly to a plastic surgeon. Often these patients are also seeing pain service, and Botox is attempted. And if that also doesn't work, then for sure requires a plastic surgeon's visit. And at the time of the visit with the plastic surgeon, again, who not every plastic surgeon, those who have been trained and perform these kind of procedures, the diagnostic block that we were talking about earlier is really the most important thing to do, because it really teases out the patients that will do well with surgery from those who will.
Sure. Okay. And so I know we're mentioning plastic surgeons. I think for so many of us, when we think of having a headache, we're often thinking of neurosurgeons. So can you talk us through a little bit about why these surgeries are typically done by a plastic surgeon versus a neurosurgeon?
Yeah, so neurosurgeons usually are taking care of the central nervous system. So usually
Hmm.
it's the brain stem, but usually peripheral nerves are actually, little known fact. One of the multiple um, tissues that the plastic surgeons take care of. Think about carpal tunnel syndrome. It's a compression neuropathy. It's exactly the same thing as occipital neuralgia, but it just happens at the level of the wrist. So it's when when the median nerve is compressed at the level of the transverse carpal ligament, which is a ligament between two bones in our wrist. And this is typical of patients who do manual labor, secretaries, right? People who type a lot of the computer, or of pregnant women who may have actually some subtle swelling of the tendons, during their pregnancy. So if you think about nerve compression, or um, tennis elbow, for example, and compression neuropathies of the ulnar nerve, or anywhere in the body, even at the level of the tarsal tunnel in the foot, etc. Plastic surgeons are really the peripheral nerve surgeons. So this is actually a great point that you bring up, because people would actually not even know that a plastic surgeon is
Hmm.
they need.
Sure. No, thank you. Yeah, for explaining that. That is really helpful. I know in the beginning of my journey, that was something that I struggled to understand for a little bit. But so we're talking quite a bit about surgery, specifically nerve decompression surgery. What are some of the more conservative treatment options that these patients should be trying before they're at the point of surgery?
Yeah, as we were saying before, medical treatment should be the first line treatment. If
Hmm.
abortive medications can actually work well, there is no reason to proceed with surgery. Um, the use of Botox, for example, if there is that muscular component, the Botox will actually help reduce, the muscular contracture, and that will actually help by distending the tissue and helping basically decreasing pain. But at that point, the block is what is going to tell you if you need surgery. And oftentimes,
Hmm.
surgery can be also just decompressive surgeries in the most usually as a first line, and in the most benign cases, in which we see that there is nerve compression. You can see that after you release the nerve in all your compression points, and the nerve is very healthy, then you are you're pretty confident that you've helped the patient. And usually that is the first line of surgical treatment because you will maintain sensation in the patient's scalp. Okay.
Mm-hmm.
But sometimes there is an even a step further that the surgeon may actually discuss with the patient, which is actually nerve transaction. And that is reserved for cases in which either the first operation was not successful and the patient can report some improvement but not total improvement, or recurrence of the symptoms, which means that the symptoms have come back. Or if you see that once that you dissect the nerve is, for example, not looking particularly healthy. So pearls usually look, they're white and mother pearly. They have a very particular consistency and look, but oftentimes you see that they're yellow and they're almost degenerating, or they're injured. In that case, the important thing to do is, of course, discuss it with the patient. You might trade the migraines for numbness. So in that case, for them to be pain free, you transect the nerve, and then you decide whether you want to bury the muscle to prevent the formation of problems later, because a neuroma could form, which is a benign tumor of the nerve, and that could actually give new pain of a different type.
Mm-hmm.
Or we can do something that we call RPNI, which is regenerative peripheral nerve interfaces, which is basically taking a little piece of muscle from the nearby muscle and basically wrapping it around the nerve ending, and maybe put a little suture there to allow it to stay in place. And that will basically give a target to the new sprouting nerve endings into a target to prevent that neuroma formation. So these are different levels, of course, of surgery that we can offer depending on what we find intraoperatively once we open the patient. But
Mm-hmm.
so medical treatment, Botox. If everything fails, pain, the pain team fails, everyone fails, then consultation with plastic surgeon as the last resource, diagnostic block to see if there is occipital neuralgia, and then surgery with the different levels of surgery depending on what we find.
Mm-hmm.
So this is really the time.
Sure. Okay. And so going back to knowing whether or not the nerve is compressed. So that's something that you're finding through the nerve blocks to identify whether the patient is going to be a candidate for surgery or not. But that compression is not showing up on imaging, right? That's not showing up on MRIs. So
Yeah.
it's the nerve
Patients
block
usually
that
arrive and they say, oh, my MRI is completely negative. That's
exactly.
great because it means that they don't have any brain masses or anything that is caused,
Mm-hmm.
or brain aneurysms, right? Like things that you have to, unfortunately, in medicine we always have to think about the worst possible case, right? So we want
Mm-hmm.
to rule out all the bad things, and then when we rule out everything, we can start focusing on things that oftentimes you cannot even see on MRI. And sometimes I'm
Mm-hmm.
pretty sure some very good, there must be out there some very good radiologists who specialize in peripheral nerve MRI readings of the head. And the truth is that is probably not very popular. So all
Mm-hmm.
MRIs get read as negative, and the patients say, well, they didn't see any compression, but that is not something that is radiographically significant, meaning the radiologist cannot really see much, but it's clinically significant, which means that that little compression or that compression and the scar tissue is there once we open the patient. It's just that you cannot see it on the MRI. And then, in fact, after the decompression, these patients are really able to go back to their life.
Yeah, and I think that's part of what is so difficult about this journey and even like reaching an accurate diagnosis of occipital neuralgia, because it's not showing up on imaging, it's not showing up on MRI. Someone's dealing with a headache, sometimes it's a constant headache for some people, and many of the physicians that they're going to, they're being told that they're dealing with migraine. Meanwhile, there's an actual compression of the nerve, so it needs to be treated differently. And this is what I've just heard so much from our members here at the Occipital Neuralgia Foundation. It's such a common concern and pathway for these patients, which is so disheartening. But there's certainly more awareness that needs to be raised, more patient advocacy. So stepping in the right direction, but
Yeah,
it's tough. So
absolutely. It's very disheartening. I totally feel for the whole community, and that's why we're here to help.
absolutely right. So going back to the nerve decompression surgery. So that's typically being done first in the occipital region. So some of our patients have reached out about this pain unmasking. I've heard it coined as.
Mhm.
So when their primary pain point initially is in the back region of the head, the occipital region. Once that is addressed, they actually notice that they have so much pain in the supraorbital or like their forehead region. Can you talk us through why that happens? Is there something that can be done in those cases? Is that expected? How often is that happening?
It's actually very common, and it's
Okay.
absolutely true. And I can make people understand it, and this is how I tell my patients in a very easy way. If you hit your knee, what do you immediately do? You go and press on your knee, right? And that basically blocks the pain. And that is because we have some neural connections between the proprioceptors, the receptors that allow you proprioception, which is, touching yourself, blocking basically a pain stimulus. Okay. Something similar happens for pain stimuli when they're particularly strong. So a stronger pain camouflages a lesser pain. But the moment you treat a stronger pain, usually the greater occipital gives you a pretty severe pain. The moment that is addressed, any smaller pain that is basically usually in an area nearby immediately gets unmasked. And it is actually very typical. I've had a patient who had exactly that. So I actually was able to take care of the supraorbital neuralgia by doing a tiny little incision in the supraorbital rim right here, about 1 centimeter, which is less than half an inch, right above the brow, so perfectly camouflaged. I was right on the nerve, and you're able to decompress the nerve. And sometimes the nerve comes from a notch in the bone, and sometimes is actually within a foramen, which means a little hole in the bone. So, on one side, I was able to actually just release it from the notch, but on one side, it was completely compressed by a foramen. So we go with a little chisel, break the bone, and really free up that nerve. And what that does really is relieve the pain. So she came back a month later, all the pain was gone, and now she had pain right here, which is interesting. So taking care of the supraorbital neuralgia actually masked another trigger point, which is typical, which is zygomatic-temporal. And I was able to release that also through a tiny little incision right in the skull. So this is an absolute true thing that happens. They're not imagining it, and unfortunately, there is that the stigma that these patients are making up their symptoms. Absolutely not.
Mm-hmm.
There's an anatomical cause for that symptom, and I would be frustrated, and I would be going out, out of my mind as well if I had migraines every day. So please, by all means, never feel like your physicians, don't believe in your symptoms, and if they do, maybe they're not the right physicians for you, and you need to find the right person.
Sure. Yes, absolutely. Thank you for acknowledging that. Yeah, it's so unfortunate, but that's kind of the journey that so many of us have had in an effort to actually find some type of relief. So let's talk a little bit more about insurance for this for nerve decompression surgery. Is this typically covered under insurance? What does that look like as well?
Yeah, so I work in a pediatric hospital,
Mm-hmm.
Because of that, we only see children, and part of the mission of our foundation is to just take care of the of children regardless. So we only basically do insurance-based cases, and so far I have not had one case being denied. I think the important points are documentation, accurate documentation in the chart of how the patient has basically done everything else that was necessary, such as PCP, neurologist, blocks, Botox, pain service, and explaining that this is basically the very last resource for the child, and
Mm-hmm.
explaining how this problem is basically affecting the child from a physical, mental, psychological perspective and academic perspective. And usually I haven't had a problem getting these cases.
Okay, that's really helpful context. Thank you. Yeah, because we even, I think it was back in 2021, it was a couple of years ago, the foundation, we ran kind of like an informal survey just to see how, like what areas can we be helping these members with occipital neuralgia. We had 7 participants who were pediatric at the time. 6 of the 7 unfortunately reported having limited access to a specialist because they were considered pediatric. So it is very refreshing to meet with someone like you who actually specializes in pediatric patients with occipital neuralgia.
That's very unfortunate. And if they're in the state of Florida, I'd be more than.
Right. So remind me again. So you are out of Orlando. What is your practice called again? Which hospital are you out of?
I'm in the at the Nemours Children's Hospital, is the hospital of the Alfred I. DuPont Foundation in Orlando, Florida. Um, we're right south of the airport, so it's also a very easy way, 5 minutes from the airport. So very easy if people want to fly in from across the state or from across the country to come and see us. And we will always have time and always find a way to squeeze these patients in. So even if there are very long consults, etc., it is such an important, impactful um surgery that it's becoming one of the few focuses of my practice and passions.
Yeah, absolutely. Well, thank you so much for your time, and thank you to everyone who sent in their questions. I hope we got through to answer most of your questions. But if you do have additional questions, absolutely feel free to reach out to either of us. And thank you again so much for your time, and thank you for all that you do for these occipital neuralgia patients.
Of course, and thank you so much for having me. And if anyone wants to contact me, they can through the hospital. They can follow me on Instagram, and they can shoot me a message there, and we can get them in touch with the hospital. Make sure they can make an appointment. So we will always be happy to see them.
Great. Sounds great. Well, thank you again so much. Talk to
Thank you.
you soon.